I have no financial disclosures. So I think from the previous couple of talks, you have come to know that mostly the cases what we see in our ocular oncology clinic, the diagnosis is kind of pretty much kind of straightforward. You see the clinical signs. Sometimes you need some kind of ancillary imaging modalities like OCT, B scan to confirm your diagnosis. However, in 10% of cases, you still the diagnosis is kind of challenging or it can be masquerading. In that context, I think the role of biopsy is very, very important. And I think biopsy from the oncology perspective, it can be either diagnostic whenever the diagnosis is kind of not straightforward or it is kind of not mismatching or not going as per your timely management. It can be prognostic in few cases where you want to understand the nature of the tumor, whether any high risk features are there so that you can predict any kind of future screening or surveillance for the patient. And sometimes the treatment itself can be the part of a biopsy, what we do. So these are the various types of biopsies which we usually do in our ocular oncology clinic, right starting from the needle biopsies, which can be done either transscleral or transvitreal. Vitreous biopsies, again, both we do in terms of rule out or ruling in kind of any infective or inflammatory or sometimes any kind of intraocular lesions, and sometimes retinochoroidal biopsies also can be needed. The instruments, I think this is very, very important slide. I think before we plan for any biopsy, I think you need to be planning well ahead what all the instruments what you need in your armamentarium so that you are well prepared and there is no surprise on the table. So I think your 23 gauge trocars, your instrumentation, needles, flute cannula, scissors, I think all things should be kept in handy before we plan for any kind of biopsy. Coming to anterior segment biopsy, I think what we usually do is either in form of aqueous tap or we can do any kind of iris or ciliary body lesions while using a needle or cutter based biopsies. And the indications usually are for any kind of iris lesions or any benign lesion like iris cyst or epithelial adenoma. Sometimes the diagnosis is not straightforward and you are kind of contemplating between a benign or a malignant lesion, and sometimes you can see some white fluffy seeds in the anterior chamber and you're not sure whether it is some kind of tumor which is masquerading in the anterior chamber. Aqueous tap, I think it is kind of straightforward. There is nothing to be known by how to do aqueous tap. You just use a 1 ml 30 gauge needle. You just put the needle into the AC, remove 0.1 to 0.2 ml of aqueous and send the material to the cytopathologist to understand the nature of the specimen. So this is one of the case which was a 58-year-old female who presented to the OPD with a kind of near total cataract. However, you could see there was a small amelanotic lesion which was residing behind the iris and it was pushing the iris in the front. There was a kind of small globular lesion seen in 4 o'clock to 7 o'clock lesion with kind of vascular malformity seen on the surface of the lesion. The ancillary imaging, as was shown in the previous presentation, we did, and it did show some kind of mass lesion usually arising from the choroid, and it was extending up to the ciliary body region as shown on the B scan. Looking at the morphology and clinical representation, a high index of suspicion for choroidal metastasis was kept in mind. The patient was advised for whole body PET CT scan, and to our surprise, it came negative. And then we thought better to do a biopsy and to confirm the diagnosis exactly from what type of lesion it is and exactly whether it is a benign lesion or malignant lesion. And this is one short video. So what we do is just take your MVR blade, make a small puncture, and before you take the biopsy, fill the anterior chamber with visco. I think this is very, very important to prevent intraocular bleed. And you can use either 29 or 30 gauge needle and with back and forth movement, and the sister is kind of aspirating the material which you're collecting through the bevel of the needle. So the important pulse, I think one is to prevent intraocular bleeding. I think you should fill the anterior chamber with the visco so that you are able to get the biopsy material and not inadvertently any kind of blood which is mixed with the biopsy material. The diagnosis which was seen on cytology again was kind of a melanocytic tumor of origin, to confirm that we were dealing with some kind of choroidal lesion probably arising from the melanocytic origin. So we went ahead and did enucleation, and the diagnosis was confirmed to be amelanotic choroidal melanoma. Coming to posterior segment biopsies, again it can be either pre-equatorial or post-equatorial. For pre-equatorial lesions, we usually use the approach that is transscleral, and any kind of lesion which is post-equator or the posterior pole, I think transvitreal approach is the best way which we do. For fine needle aspiration biopsies, I think the technique what we use is intravitreal technique, and it can be used either using your indirect ophthalmoscopy or your vitrectomy systems. So I will show a case. I think this was a 52-year female who again was diagnosed to have kind of amelanotic choroidal lesion, probably of tubercular origin. She was on 6 months of anti-tubercular treatment. However, there was no response to anti-tubercular treatment. All the investigations, at least NCD imaging modality, showed it to be a kind of amelanotic variant of choroidal melanoma. However, the patient insisted on biopsy before going for any kind of plaque radiation treatment. So this is the video which shows where after 3 ports transscleral transvitreal biopsy, where we use a long 24 gauge needle which kinds of penetrates at the most prominent portion of the tumor, avoiding any major retinal blood vessels, and at the same time sister is kind of aspirating with 2 ml syringe attached to a short tubing, and this material is collected freshly and sent to the cytopathologist within 30 minutes of collection. In this, I think the important pearl is to increase the IOP whenever you're taking the biopsy, because there is high chance there might be bleed. So make sure that the intraocular pressure is around 60 millimeters of mercury. And again, to our confirmation of clinical diagnosis, the diagnosis was confirmed on histopathology to be melanocytic origin of cells and probably a melanotic choroidal melanoma. Both the histochemistry stains for melanin A and HMB45 positive. So sometimes we do needle biopsies again in case of melanocytic choroidal lesions, probably for prognostic purpose, particularly in case of choroidal melanoma, and it does helps us to plan for future surveillance testing, particularly when we look for any metastasis related to choroidal melanoma. Vitreous biopsy, I think this is what we do day in, day out for all of endophthalmitis or uveitic conditions. However, in cases which are not responding to your treatment, or you feel there is a high index of suspicion for intraocular lymphoma, then we go ahead and do vitreous biopsies. So this is one of the case which on clinical suspicion, it was looking very, very similar what Dr. Swati showed, a case of primary vitreal lymphoma. On the OCT again, which was elaborated by Swati, you see the sub-RP infiltrates, and why we did biopsy. I think I come from a school of thought, unless and until I have the histopathology gold standard to in my hand, I don't start any treatment. So I went ahead and did vitreous plus sub-RP biopsy. Usually we do only vitreous biopsies for intraocular lymphoma. However, from the initial papers from Shields as well as from few other multi-institutional studies, they have shown that if you take the biopsy from the sub-RP space, where actually the origin of the lymphoma cells is there. So this is the video which shows I have done the biopsy, both diluted as well as the undiluted specimen from the vitreous cavity. And for the sub-RP biopsy, what technique I used this small needle which is directly entered into the sub-RP space, and I aspirate the sub-RP material directly from the area where the origin of the tumor cells is there. And the pearl, again, you need to collect specimen both in undiluted as well as diluted. And for the bevel, for the soft tip cannula, what I was using, always use a bevel cut at the distal end of the cannula, so that when you entered with that bevel, it easily enters into the sub-RP space. And this material is then sent for the biopsy. This again confirm our diagnosis of diffuse large B-cell lymphoma with CD20 positive, and patient was started on intravitreal methotrexate regimen, close to 24 injections over a year. Sometimes we need to go ahead and do one more biopsy in advent related to vitreous sub-RP, and go ahead with retinochoroidal biopsy. And this is usually done in conditions where the patient is not responding to your treatment, or the fellow eye is threatened despite seemingly appropriate therapy. So this is one of the case which was diagnosed to a VKH, was treated for VKH in terms of oral steroids and immunosuppressants. However, the patient was not responding as per the clinician's discretion. They went ahead with the biopsy. At that time, they just showed reactive atypical cells. However, on the OCT, again, you could see there were multiple yellowish RP infiltrates, and there was a high index of suspicion for intraocular lymphoma. So we went ahead and did a repeat biopsy, and at this, because already vitreous was biopsy, there was no material which we could collect from the vitreous. So I went ahead and did a sub-retinal biopsy as well as retinochoroidal biopsy. So this is a short video where you can see I'm just selecting an area where clinically I know there is a high chunk of material particularly related to the lymphoma cells, and I am choosing an area which is very adjacent to a area where the normal retina is also there, so that when I send the specimen to the pathologist, it becomes easy for them to compare it with the normal retina. I usually use diathermy all around the lesions 360-degree, and then with the chandelier illumination and bimanual technique, I use scissors and forceps to remove this layer of the retina as well as the underlying choroid. So always the pearl which is there, you always choose the normal adjacent retina so that the pathologist can compare with the atypical retinochoroidal layer, as well as you always use good diathermy to reduce any inadvertent choroidal bleed which can happen particularly when you do a retinochoroidal biopsy. Diagnosis was confirmed to be large B-cell lymphoma on histopathological examination. I will just go to the last part of my talk, which is excision biopsy. Sometimes we do remove the tumor in toto, which can itself be a therapeutic treatment for this intraocular tumors. So this is one of the case of retinal capillary hemangioblastoma. The diagnosis is straightforward. There is nothing you need any biopsy or anything for this. Systemic screening, again family screening, it was kind of very straightforward. However, you could see there was a multiple large retinal hemangioblastomas, particularly 2 in the temporal quadrant, and there was subretinal fibrosis as well as preretinal fibrosis and traction detachment. So considering the patient's one-night status, I went ahead and did en-block resection of the tumor, where after the core vitrectomy, a feeder vessel ligation was done, particularly to block the vessel which was supplying the feeder artery which was supplying the blood to the capillary hemangioma. After that, a good diathermy was done all around the tumor so as to prevent any inadvertent bleeding from the capillary hemangioblastoma, and then this tumor was excised in toto, which I can just show in the end. So yeah, so this is the tumor, how it was removed in toto from the tumor. And at the end, I think the patient did had a retina attached with silicone oil in tamponade. And this is last case. Again, this is a case of a congenital simple hematoma. The clinical diagnosis was very kind of straightforward. The OCT does shows the origin of the cells from the RPE. However, the patient had macular traction and decrease of vision over the 2 years. So the approach was simple. What we do for any macular hole surgery, we did core vitrectomy, induced PVD, and through bimanual technique, we did remove the tumor in toto and sent for histopathology, which confirmed the diagnosis to a congenital simple hematoma of retinal pigment epithelium. So I will like to give my concluding slide. So I think in ocular oncology, surgical biopsy still remains the gold standard of care because of its unique ability to provide tissue samples for direct histopathological analysis and also to bolster our diagnostic certainty. Appropriate surgical technique, careful tissue handling, and consultation with expert pathologist is very, very essential to reach to a confirmed diagnosis. Negative biopsy doesn't rule out any possibility of intraocular tumors, and if needed, need to go for a repeat biopsy. And multidisciplinary approach where your ophthalmologist, pathologist, and neuro-oncologist is the need of the hour. Thank you.
Thank you, Vishal. Thank you for the beautiful videos showing the